factors that I talked about earlier, those are the patients for whom we really have to tailor our treatments, including considering combination therapies. Now, in terms of the combination studies, first of all, I think it's important that we as clinicians, this is a place we can really use the art and the science of medicine. If we choose treatments that are shown to be effective and treatment combinations that have a synergistic rather than just an additive effect pharmacologically, we may end up getting better outcomes. Examples there, lithium and divalproex may have two totally different mechanisms of action, or lithium and divalproex with an atypical, different mechanisms of action, rather than looking at things like two atypicals together. There is data, obviously, to show the combination treatments in many patients will show superior outcomes. And Terry Ketter actually published a good meta-analysis of the response rates looking at both the monotherapy studies, whether it was looking at lithium, divalproex, carbamazepine, or the atypicals as monotherapy relative to placebo. But also when you look at response rates in the combination treatments, where an atypical was used in conjunction with divalproex or with lithium relative to monotherapy with the lithium or divalproex. Again, many of these studies, they varied in methodology, as I'm going to show you in these next few slides. Very important to make sure that adequate doses of the core mood stabilizer are actually used. Because in some of the studies, there may have been inadequate doses based on serum levels of the core mood stabilizers like lithium or divalproex. This is Towen's study basically showing lithium or divalproex plus olanzapine in acute mania. And again, there is a statistically significant advantage to the combination therapy. And I think the important question that we have ahead of us, how long will patients require combination therapies like this? And you know, we often take the adage, what gets patients better will keep them better, but we always have to consider issues around not only efficacy, but safety and tolerability. Similarly, Gary Sachs' study with risperidone with a mood stabilizer or the mood stabilizer with placebo showed a statistically significant advantage of the mood stabilizer with the atypical, whether the atypical was risperidone or haloperidol, relative to the mood stabilizer alone. But here's another good example of making sure the patient had a good therapeutic dose of a mood stabilizer because, again, many of these studies varied in methodology and may have not had patients on an adequate core mood stabilizer. Another study, and again, this being done in an adolescent population, looking at divalproex alone in a placebo-controlled trial or divalproex plus quetiapine, again, getting a little closer to the therapeutic dose ranges for the divalproex, but again, a little bit of an advantage of the combination relative to just the monotherapy group.
John, it seems to me that we're in a bit of a bind as clinicians, and the combination therapy data that you presented is mostly in inpatient studies, I think, with the exception of the Towen study, right, which had mostly outpatients. But I think that those data present a pretty compelling argument. If somebody's in the hospital, two anti-manic drugs are usually better than one, at least for rapid response and just overall rate of response or percentage-wise. But we want, for the long run, to keep people on as few medicines as possible and to avoid what Rick Shelton calls the Velcro effect, which is, you know, somebody's on one drug right, and then their breakthrough symptoms and they're on a second, and then their breakthrough symptoms are on a third. So how do we manage that apparent tension there between maximizing response to one or more drugs and yet constantly trying to say, is this the right regimen for somebody?
Paul, first of all, it's trying to avoid adding drugs if we can. I go back to making sure we've maximized doses. You know, a little bit, we don't know whether a little bit of drug A and drug B and C will make one good combination. If we have at least one good solid dose, we may be able to avoid it. Later on down the line, yes, I think it's important once the patient is stabilized to look at what are the treatments that may not be playing such an important role? Sometimes we have to add things to sort of treat the roughening of the illness, to treat sleep, to treat the anxiety, the agitation. But whether we need that in the long run, if we have some good solid doses of mood stabilizers along the way, we may be able to avoid that Velcro phenomena.
Thanks.
And there are, again, I mentioned this already, some of the problems with the combination studies is that a lot of these studies could have used probably higher doses of the lithium or divalproex to really ascertain whether there is a true difference. Studies are going on as we speak where, and they are double-blind studies of peeling away some of these medicines, but these studies were designed in a way to make sure that there were therapeutic doses of lithium or divalproex and before paring away the atypical antipsychotic in this case.
Yeah, I'm glad you brought up the studies that are ongoing because although it's, as you pointed out, and as we all know clinically, it's combination or more is very commonplace in people with bipolar disorder in the long run. There are vanishingly few studies that actually ask the question, are two medicines better than one in the long run?
Right.
So those studies should help us from a clinical standpoint soon. John, let's go back to our case and reveal the polling results. I want to mention, by the way, that this case is a real person. This young man was a patient of Dr. Zajeka's, so John will be able to actually give us firsthand evidence of what the outcome was and what he did. But to remind you, this case was a 21-year-old male college student who presented at the emergency room accompanied by his parents following a call from his friends that he was arrested and being transferred from a jail to a city mental health center in Europe. We asked you to vote on what would be an appropriate acute and long-term intervention for this patient. And this is what you said. Let's turn to the graphic now. Interesting. Looks like the most popular, by a hair, response was to add olanzapine 15 milligrams per day to lamotrigine, or in this case, simply put, not to discontinue lamotrigine. The second most common response, with about 35% of people, was to actually reduce the lamotrigine dose a little bit, but add, in this case, another anti-manic agent, olanzapine being an option B, and in this case, divalproex sodium extended release. Distinctly unpopular was to do nothing except discontinue his lamotrigine, and then a kind of intermediate response was adding carbamazepine extended release to lamotrigine. John, what do you think of the responses, and what did you in fact do?
It's almost a bell curve here.
Yeah.
It's an interesting point, and part of it is acute versus long-term. And this is a provocative question. I mean, if you have someone who is acutely manic, yes, we may be able to get it under good control with olanzapine, and I see a lot of individuals actually said that. Long-term wise, will that be the optimal agent for an individual who already stopped medicines because he did have significant weight gain on some of the other agents? Yeah. And so, in terms of C and D, and obviously somewhere lamotrigine had kept his illness under okay control from his depression standpoint, but obviously had breakthrough manias. So somewhere he needs good mood stabilization for long-term control. In terms of follow-up, we could talk a little bit about that, but it's an interesting response.
You can go ahead and describe it.
Well, this patient was given clonazepam, and his lamotrigine was actually reduced to 100 milligrams. As we know, divalproex can double the lamotrigine levels. Carbamazepine can reduce it by half. So that's the tricky part. But in this case, I chose to actually add divalproex sodium in the extended release formulation, but I did that by reducing the lamotrigine and then adding the divalproex. His divalproex was 2,500 milligrams, and as you can see here, this is getting back into how quickly I may go up by the second night. 4 days later, his level was at 94. He was significantly less irritable. This is a guy, by the way, when I saw him at this point, was very, very irritable, the classic mixed patient. Yet a few days earlier, he had the classic euphoric picture, and how quickly people can go from one state to another. The clonazepam was eventually discontinued. Obviously, this was, a Band-Aid to help with sleep initially, and his LFTs eventually returned to normal.